Hello, this is Dr. Scott McLean, and this is a YouTube video about implant dentistry. For today's patient, we have an 80-year-old who requires the replacement of an upper left central. So we're going to do this with an immediate placement type of protocol. The patient did present with the crown off, and then we actually cemented this back on. As you can see in the x-ray, there's not a lot to work with from point to restore this with typical post and core. So we wanted to do an atraumatic extraction, so using a peritome. You want to stay away from the buccal bone. It's okay to kind of separate the tissue, but stay away from the buccal bone with the peritome and get this actually down into the periodontal ligament space so you're able to get this root moving to get this out without any issues. Now it's very likely that the crown will come off during this procedure because it's actually only glued on very lightly because of the actual structure that's underneath there. So once we get the crown off, we want to make sure we're taking this root out without damaging that buccal bone, because the buccal bone is where we're going to have to do some bone grafting later on. And so we need to kind of maintain this area for aesthetics and also for the success of this treatment. So as you can see, the root came out fairly easy. Once the root is out, it's our goal to assess the situation and see if we're able to do an immediate placement. So we take the peritome and actually feel the buccal plate and make sure it's intact, because if it wasn't intact, I would usually abort this procedure and go to typical ridge grafting and keep everything online. But we do have a nice buccal plate here. The goal is to place the implant in a position not where the tooth was, but actually into the palatal wall or into the lingual area where the bone is very stable. And this allows us to get into a screw retained position for implant placement. So we'd rather be lingual than buccal in this position because of the stability of this bone. And we get too close to the facial plate if you try to put it where the tooth used to be. So you have to notice the angle of the drill. We're using a precision drill, and we're going to actually angle it very much palatal and then rotate the hand as we're going in to make this go into that screw retained position. When using the precision drill, we want to maintain our vision on the two roots that are adjacent, because we want to stay parallel with these roots, but also to hit this target up inside where we were going into the palatal wall. So our next drill we're going to use is the 2mm twist drill, and we'll still follow this on an angle when we first start the osteotomy, just so we can engage that palatal wall, but it's very important to follow where that precision drill has just made that first start of the osteotomy. So we're following this in, making it a little bigger, and we're rotating as we go in, so we're actually pushing the bone a little bit at the same time as cutting it. To check our angulation, it's important to place an x-ray guide pin, and then we're able to see visual that we're in a good position, but also to take an x-ray is always prudent to make sure we're in the right position mesial distally. So we're going to place a 3.5mm narrow platform Noble Active, and using a surgical driver, which is the choice of instruments here, we're going to take the implant to the mouth, carrying with the surgical driver. Now, the surgical driver is going to enable us to position this in that palatal position. We actually start very, very buccal, and we want to do this on purpose. So we start buccal, so the threads are so aggressive and stable that we're able to rotate this implant as we go in. So as you're going into that osteotomy, you rotate your hand backwards into that lingual position. When you're preparing the bone for this type of procedure, you need to actually under-prepare a little bit, because just about only the 3mm or more of the implant is going to be in bone on the palatal wall. So we do have to have that ability to get that implant up to about 70 newtons. We want to definitely be above 35 newtons to do this procedure, or you have to abort. If you abort the procedure, you put on a healing abutment flared to 5mm to help seal the socket, but also to preserve the papilla. So we have this 3.5mm implant in. Now it's important to make sure that we have this at the right level. So, and we see the x-ray, it's looking good. I will either put the cover screw or the immediate temporary abutment on prior to bone grafting, because what we're going to be doing is to buccal graft into the jump gap. So we're going to put some allograft up in this area so that we can help to preserve that buccal plate and keep that area kind of aesthetically more pleasing. So it's thought that by placing the bone graft in the jump gap, that it prevents the shrinkage of the bone and keeps that from being a little bit more apt to have some recession. So here we're placing the allograft, and then we're going to take that cover screw back out so that we're able to then put on our medial temporary abutment. It just gives a little bit more room to use the cover screw, but the abutment could be placed. We just don't want the bone graft going inside of the implant and filling up the implant and having a problem when you go to put on other abutments later on. So here we're taking the immediate temporary abutment. This is going to be placed on, and we're going to tighten this abutment down to 35 newtons, or you can go somewhat under that as well. But ideally, you want to be able to have that abutment stable, and then we're going to come back and create the beautiful temporary crown once we know that this is in position. So here we are, we're just checking the occlusion to make sure that there's enough space, because you can get a 3.0 millimeter immediate temporary abutment, which is a little bit longer, and then we're going to torque this down. So once we torque it down, then we're able to put on the white cap. So you can see here's a picture of the implant with the abutment on top, and this is what you're looking at. So we'll make our immediate temporary crown, and then we'll be off to getting this restored in about 3 to 4 months. This is Dr. Scott McLean, and this has been a YouTube presentation about implant dentistry.